Hello and welcome to this talk on psychopharmacology. This is an introduction to psychopharmacology primarily intended for medical students, although it could be a useful introduction or review for people at different stages of learning. My name is John Wurzel. I'm one of the faculty psychiatrists at Sacred Heart Medical Center and at the Spokane Teaching Health Clinic in Spokane, Washington, and I appreciate you joining me. Over the course of this lecture, we're going to review in detail 3 classes of medications, so antidepressant medications, mood stabilizer medications, or medications that we use to treat bipolar disorder, and antipsychotic class medications. And then at the end, we'll briefly go over some commonly used other medications in psychiatry, including sedative hypnotics, medications to support sobriety, stimulants, and medications that we use to treat dementia. I make a couple assumptions about what knowledge you bring to this discussion in order to get the most out of it. So the first is that you already have a basic understanding of what medication classes we use to treat various psychopathologies. As we'll see over the course of this talk, choosing the right medication for a psychiatric illness can be quite complicated, but it also can be fairly simple. The most basic level, simply applying the prefix anti to the name of the illness, is a pretty good place to start in psychiatry. So antidepressants are a useful treatment for depression, antipsychotics a useful treatment for psychosis, etc. I also assume that you already have a basic knowledge of how these mechanisms work, and that we will not need to review mechanism of action during the course of this talk. In terms of our objectives, by the end of this talk, I would hope for you to first understand how to pick an antidepressant medication based on an algorithm, efficacy understandings, and side effect profiles, and for you to be able to use that understanding to have a logical approach to picking antidepressants for your own patients. Second, for you to understand how to pick appropriate medications for bipolar disorder in its various stages, based again on efficacy and side effect profile, and to again have a logical approach to recommending medications to your patients with bipolar disorder. And third, for you to understand the efficacy and side effect profiles of various antipsychotics, and hopefully for that to help inform how you might recommend one of those to a patient suffering from a psychotic disorder. Turning our attention to the antidepressants specifically, we've got to start by answering the question, what are we attempting to treat with these medications? And so I'm going to ask you to pause the video and write down a list of what conditions are most appropriately treated with an antidepressant. So go ahead and pause it now, write that list. All right, now let's check your work. So probably the lowest hanging fruit is major depressive disorder. We also use antidepressants to treat dysthymia, which is now known as persistent depressive disorder in the DSM-5. We use it to treat double depression, which is essentially a persistent depressive disorder that is interrupted by bouts of major depression. And we also use antidepressants to treat anxiety disorders, including generalized anxiety disorder and panic disorder. We use them to treat obsessive compulsive disorder. We use them to treat post-traumatic stress disorder. We use them to treat some eating disorders. The evidence base for antidepressants in the treatment of eating disorders really suggests that bulimia is the most responsive eating disorder to antidepressants. Anorexia nervosa doesn't respond particularly well to antidepressants, but those patients with anorexia have very high rates of comorbidities from the depression and anxiety spectrum that are still often appropriately treated with those medications. And then we occasionally use them to treat premenstrual dysphoric disorder and a few kind of assorted other things. We also have to think about what we shouldn't be using antidepressants to treat. And probably the biggest one that I see where they are misused in an attempt to treat an illness is bipolar disorder, which we'll come back to during the subsequent talk on what is appropriate to use to treat bipolar disorder. Often antidepressants are also used to treat personality disorders. The personality disorder itself tends to be fairly unresponsive to antidepressants, although as with eating disorders and many other things, there's a lot of comorbid depression and anxiety that could very well be appropriately treated with an antidepressant in the setting of a personality disorder. Now, the heart of this lecture is to help you to understand how to make an educated recommendation about which antidepressant a patient might want to try at any given point in their treatment course. Often, making recommendations for antidepressants can feel kind of like you're shooting in the dark. It's hard to know why you might recommend one over the other, and that's complicated even further by the fact that the list of antidepressants available is quite long. So these are the antidepressants that I've used in my clinical practice at various times that I've prescribed. And despite being in academic medicine for years, there are even some other antidepressants that I've never prescribed, although I think at this point I have probably prescribed both vilazodone and vortioxetine. I've never prescribed Eleptro, and I've never prescribed Fetsima, and there's quite a few of the tricyclic antidepressants that I've never prescribed also. So it can be really hard to know how are we going to look at this long list of options and pick one in an educated way in order to recommend to our patient. So the first question we have to ask then is, how do we pick a medication for any condition, whether we're picking antibiotics for someone's infection or we're picking antidepressants for someone's depression? The first thing we want to think about is always the same, and that is, how well does this medication work to treat that problem, right? So we want to look at efficacy. And we want to ask which antidepressant is the most effective. The answer to that, in short, is that they all work about equally well. But let's look at the data. So this is from STAR-D. So STAR-D was a big naturalistic study, one of 3 big studies funded by the National Institute of Mental Health in the late 1990s and early 2000s. And STAR-D looked at the treatment of depression. These studies were all naturalistic, which means that the patients were being treated by their usual psychiatrist in the usual way of treatment. No one was counting their pills, no one was checking blood levels for a medication that one wouldn't typically check blood levels for. There was no additional wraparound services necessarily provided. It's just treatment in the usual treatment setting. And what they did was they found 3,600 patients, and they started them with depression, 3,600 patients with depression. They started them all on citalopram. And if we look over at the chart here, what we have is up on the top, that's level 1. Level 1, everyone went into level 1, everyone got started on citalopram, and now we're seeing this black bar and this gray bar. Now, all of the patients were being rated on this QIDS-SR rating scale, which is just a scale that's used to numerically score depression symptoms. And the black bar represents the number of patients who went into remission. And remission is defined as their QIDS-SR score fell out of the clinical range. They were no longer depressed. The gray bar represents the percentage of patients who had a response to treatment, and response is defined as a 50% or greater reduction in their symptoms. And so what we can see if we look at the black bar and the gray bar is that about 30% of people will have a remission, and about 50% of people will have some response to the first trial of an antidepressant. That's been replicated and generally true in multiple different placebo-controlled double-blind studies for most of the antidepressants. Those numbers are all about the same. But what the STAR-D study then did was said, okay, of the people who didn't have adequate response to their first antidepressant, citalopram, we're going to switch you or augment you with another antidepressant. And so then we look down and we look at level 2. Now you can see there's a lot of different things you could switch to and a lot of different augmentation strategies. But for the purposes of determining which ones are best, what we can see is that within those boxes, the black bars and the gray bars for any given intervention are all about the same, with the exception of CT. CT stands here for cognitive therapy. This is the only time in this pharmacology talk that we're going to discuss cognitive therapy, but I would like to point out that cognitive therapy is as effective as antidepressants for mild to moderate depression and has a more durable, long-lasting action, right? So people stop responding to antidepressants when they stop taking them, but they continue to have the skills that they learned in cognitive therapy even after they finish the therapy. And that said, back to the pharmacology. We look at the black bars and the gray bars and we would conclude, oh, bupropion, sertraline, venlafaxine, those are all about the same, right? Augmentation strategies are beyond the scope of this sort of basic lecture, and so I'm going to encourage you to skip that. For the people who, again, didn't adequately respond to their second trial of an antidepressant, they went down to level 3 and were either switched to nortriptyline or mirtazapine or had a couple augmentation strategies, again, beyond the scope of this conversation. If they didn't respond to level 3, they were then switched down to level 4 and put on tranylcypromine, which is an MAOI, or this combination of venlafaxine and mirtazapine together. Now, just looking at the bars in this graph, one would potentially argue, wow, it sure looks like citalopram works better than any of these other antidepressants, but we're kind of comparing apples to oranges if we say that, because citalopram works well in people who have not failed antidepressants. The level 2 patients are defined as being patients who have already failed one antidepressant. The level 3 patients are defined as being patients who have already failed 2 antidepressants, etc. So you can't really compare between the levels, but if we look within the levels, what we see is that there really isn't a lot of difference. It's also clear that people who are medication naive, who are trying their first medication, have a better chance of either remitting or responding, and that if we look down at levels 3 and 4, the more antidepressants you've failed, the more likely you are to fail the next antidepressant that you try. And finally, again, looking within the levels and comparing, there really is no difference between the various antidepressants and the rates of remission or response, and that's been borne out across multiple studies. So all of the antidepressants work about equally. There may be some subtle differences in the efficacies of the various antidepressants, and there's a reference at the end that's a nice paper that walks you through those subtle differences, but I would say that there are not significant enough differences to guide my clinical judgment in terms of efficacy. So we haven't actually made much progress in terms of helping to pick an antidepressant to recommend, because we've determined that they're all about equally efficacious. So we want to look at something else. They're usually chosen based on a rough algorithm and then adjusting that algorithm for the side effect profile. So looking back at the STAR-D study for an algorithm, you can see they went to citalopram and then followed up with some switch strategies and then some further switch strategies. And if you can't remember any other places to get an antidepressant algorithm for, STAR-D is very reasonable. That said, I think my algorithm is pretty good, though, and this is something that I've developed working with a bunch of colleagues, and it's certainly not like it's my algorithm. This is the algorithm that I use, and it starts with a selective serotonin reuptake inhibitor, usually as the first step, possibly a serotonin norepinephrine reuptake inhibitor or mirtazapine. So the second step, we'd pick a different SSRI or SNRI, consider bupropion, which is a dopamine norepinephrine reuptake inhibitor, or think about mirtazapine, often switching classes. As a third step, we would certainly be switching classes. And then as a fourth step, if they failed the first 3, I'd be thinking about tricyclic medications, I'd be thinking about augmentation strategies, I would certainly be thinking about ECT, and going from there. The odds of someone responding to their 4th antidepressants, if they've already failed 3, looking back at the STAR-D study, are about 14%, which is not very good. Whereas the odds of them responding to ECT can be as high as 80+%, which is really quite remarkable, and so it certainly should be on your radar. We also have to ask, how does my patient move through this algorithm? How do they get from step 1 to 2 or 2 to 3, etc.? And the answer to that is therapeutic failures. So there's a lot of reasons that you might recommend for your patient to change medication, but the only one of those reasons that would move them through the algorithm is therapeutic failure. And what that means is that your patient has tried the maximum dose of that medication for at least 6 weeks. As we'll talk about, these medications can take 8 to 12 weeks before you see their full effect, but there's good studies that suggest that if they've seen no improvement after 6 weeks on the maximum dose, it's probably not going to work, and it's a reasonable time to switch. If your patient starts taking the medication and can't tolerate it, let's say that they get, a lot of diarrhea from sertraline, that's a very reasonable indication to switch medications, but it wouldn't make me think we need to move through the algorithm. So if they were on sertraline at step 1, I would just switch to a different SSRI, maybe put them on Prozac, and see whether they could tolerate that better. If they can't tolerate anything within a class of medications, then you want to use your clinical judgment and decide, okay, maybe I probably shouldn't try those medications anymore, and take that into account as you go through the algorithm. So we have to ask, why is the algorithm the way that it is? Given equal efficacy, why are these SSRIs first line? And the answer is safety, right? So the algorithm is organized essentially by decreasing therapeutic index. The further you go down in the algorithm, the more dangerous the medications are in overdose. And so therapeutic indices look like this. SSRIs are safer or equally safe to mirtazapine, which is safer than bupropion and the SNRIs, which are significantly safer than tricyclics and MAOIs, which are actually fairly dangerous in overdose. So that's why the algorithm looks the way it does. So we said that we're going to pick a medication to recommend based on locating the patient in the algorithm and then adjusting for side effects. And so we have to ask, well, what side effects do we care? And if we rephrase that question, what comorbid symptoms or diseases do my patients suffer that I could help them with or should be particularly concerned about? I'm going to ask you to pause here and think about your answer to the question, write that down, and try to think of as many comorbid symptoms or issues as you can that would influence your selection of antidepressants. Great. So here are the ones that I typically consider. I start by thinking about whether the patient's struggling with insomnia or hypersomnia, how their energy levels are, whether they have comorbid anxiety or ADHD. I think about whether they're obese or anorexic, and that anorexia may be secondary to an issue like depression or an issue like psychosis or dementia, or it may be because they have anorexia or some other restrictive eating disorder. I think about whether the patient has substance abuse problems, because some of the antidepressants can be helpful with those specifically, about pain, about headaches. I'm aware of impaired sexual function, right, which typically is either mechanical or libido, right? So there's, in men, they have premature ejaculation or impotence, and or impaired libido, and in women they can have poor lubrication or anorgasmia and or poor libido. I also think about seizure disorders, and so these are kind of the side effects that I'm going to be adjusting my algorithm in consideration of. So we started looking at this really long list of antidepressants, and this is kind of where we're going. So these are the medications that I most commonly use, including sertraline, escitalopram, fluoxetine, mirtazapine, venlafaxine, duloxetine, and bupropion. And what I want to help do over the course of this lecture is help you to understand why these medications, why are these reasonable medications to be picking from. And so I'm going to walk you through my logic. So like I said, we're going to start with an SSRI because it's safe, ideally, and then I'm going to look at the patient on the algorithm, and then step 2, I'm going to think about, does this patient need help sleeping or being more active, right? So if we organize our medications, our antidepressant medications, from most activating to most sedating, I'm going to have you pause here, write down how you would organize the medications from most activating to most sedating. And here's kind of the way I think about it. So bupropion is the most activating of the antidepressants on average, followed by venlafaxine and duloxetine, and then you're going to be into your SSRIs with fluoxetine. It's generally considered the most activating of the SSRIs in adults. Sometimes sertraline can be in children. In adults, you're looking at sertraline, citalopram, and escitalopram as being fairly neutral, and paroxetine as being the most sedating of the SSRIs on average, and then mirtazapine, trazodone's quite sedating, and then we have our secondary tricyclics and our tertiary tricyclics. Now, I haven't discussed every medication in the antidepressant class on this list, and I'll tell you why I dropped off some of them already. So some of them are very new and very expensive, so new medications tend to not only be expensive but also poorly studied, and so none of them seem to be remarkably better than the ones on this list, and so I'm going to wait until there's better data and less expense involved in using those. The MAOIs, I think, are largely beyond the scope of medical student psychopharmacology, and so I'm not going to include those here. They're also hard to locate because they can cause anything from sedation to insomnia, and they wouldn't fit well on this graph. And then a few of the less commonly used medications I've also decided just not to include here. So these are, of the commonly used medications, how I would organize them from activating to sedating. And these little red lines denote where I think about changing from the activating classes to the neutral classes to the sedating classes of medications. Now, anyone can respond to any one of these medications in any way. So I've had patients who take bupropion at night because it's sedating. I've had patients who take paroxetine or Paxil in the morning because it keeps them up. You want to respect whatever your patient is describing as their symptoms, but in general, this is the way that I think about them. And then I'm going to start thinking about other side effect considerations. So we talked about potentially obesity and anorexia and trying to help the patient manage their weight. So why don't you pause real quick and write down which medications cause weight gain, which ones are neutral, and which ones cause possible weight loss of the antidepressants. All right, so the ones that cause weight gain, as a general rule in medicine, not universal, but general, things that make you sleepy also tend to make you gain weight, and so those would include mirtazapine and paroxetine and your tricyclics. Trazodone isn't notable for causing weight gain, FYI. The neutral ones include sertraline, escitalopram, citalopram, venlafaxine, duloxetine, and the one that can be helpful for weight loss is bupropion. Next, I want to think about other considerations. So some of our antidepressants can be helpful for substance abuse issues in patients who struggle with those. So hopefully you all know about bupropion being useful for nicotine tobacco dependence. There's some evidence that mirtazapine is actually helpful in assisting patients to stay sober from methamphetamine. It's not a miracle drug, but it's a little bit helpful, and so that would be a consideration. When we think about things that are useful for helping patients with ADHD, there's some evidence for bupropion as a third-line agent and venlafaxine as sort of, I guess, a fourth-line agent. I think about which ones might be useful for pain, specifically neuropathic pain, and those would include duloxetine, venlafaxine, amitriptyline, and other tricyclics. Probably something about the noradrenergic effects of those medications, although duloxetine doesn't seem to be as helpful. The ones that are useful for migraine headaches as a prophylactic agent, not an abortive agent, include amitriptyline and other tricyclics. And when we think about sexual dysfunction, which depending on the study, 25 to 70% of patients on an SSRI will experience, the two that really don't cause sexual dysfunction are bupropion and mirtazapine. There's some suggestion that some of the newer ones may not cause that. I'm going to wait to see when there's non-industry funded studies on those medications whether that continues to be true. But if the patient's had a lot of trouble with or is very worried about sexual dysfunction, I generally would look more toward bupropion or mirtazapine when I'm recommending antidepressants. If I'm worried about seizures, I want to be cautious about bupropion. It's useful to remember that we're kind of often taught that bupropion can be dangerous in patients with eating disorders, which is true because they have electrolyte abnormalities that increase the risk of seizures, but bupropion also merits caution in anyone who's at risk for seizures, including people with pre-existing seizure disorders, people who've had brain surgery or neurologic disorders, or other issues where electrolyte abnormalities are a realistic possibility, including eating disorders, but also renal issues, GI issues, etc. Bupropion does lower seizure threshold. If your patient's under 18 years old, the two landmark studies looking at pediatric depression and anxiety used fluoxetine and sertraline respectively, but generally the consensus among child and adolescent psychiatrists is that, particularly for adolescents, antidepressants work about the same in those populations as they do in adults. That said, all antidepressants carry a black box warning for increased suicidality in adolescents and young adults with an age cutoff of 26. When we turn to look at specific medications, so we'll start by talking about paroxetine and why I pretty much never prescribe it. So paroxetine is a potent inhibitor at CYP2D6 and also a substrate at CYP2D6, which means, if you think about it, that when you're taking paroxetine, it's actively inhibiting its own metabolism, right? So it's helping maintain your blood levels of that medication, which isn't particularly hard to manage when you're increasing the dose. You just adjust the maximum dose appropriately. But it is hard to manage when you're decreasing the dose, because if you imagine the kinetics of getting off of paroxetine, what's going to happen is, as you take less of the medication, there's less inhibition of its metabolism, and so your body metabolizes it faster, and so you clear it faster, and so your body sees this rapid acceleration in the rate of decrease of paroxetine in your bloodstream, which is a great setup for a withdrawal symptom. It's not medically dangerous, but it can be quite psychiatrically dangerous. I've had patients hospitalized for paroxetine withdrawal. They come in with profound dysphoria, suicidality, a lot of anxiety. Kind of pathognomically, they describe these shock sensations inside their brain, almost like they're getting static electricity shocks inside their brain. And then you give them a dose of Paxil again, and suddenly they feel better. It's pretty clear that they're in Paxil withdrawal. It's also the only antidepressant that's clearly contraindicated in pregnancy. It increases the rate of spontaneous abortions. It also makes your patient sleepy, causes weight gain, interacts with lots of other medications. So I almost universally steer clear of paroxetine. When we look at fluoxetine, Prozac, so there's one major plus and minus to Prozac, and that is that both fluoxetine and norfluoxetine, which is an active metabolite, have half-lives that are measured in days, which means a single dose of fluoxetine can actually be used to prevent serotonin withdrawal from other antidepressants like paroxetine, because it'll self-taper, but it also means that if your patient has nasty side effects to the Prozac, then one dose of Prozac can give them days worth of nasty side effects, so it's fairly uncomfortable. I don't think it's a good reason to not use it, and sometimes we pick Prozac because, this particular patient sometimes forgets their medication, and we want something with a long half-life. And Prozac's a great choice, but I always warn my patient up front. In terms of citalopram, so citalopram was identified by the FDA as having this potential for QTc prolongation. I don't think it actually has a warning. It has a dose limitation that limits it to 40 milligrams as the maximum dose, while the maximum dose used to be 80 milligrams. Now, unfortunately, the FDA didn't have a magic wand to wave to make 40 milligrams work as well as 80 milligrams used to, and so citalopram isn't a particularly useful antidepressant in patients who are going to require high doses of the medication, so I tend to avoid it in those patients. Also, if they have a history of sudden cardiac death in their family, or a personal history of heart problems, I would be more wary around citalopram. When we look at tricyclic antidepressants, and this is why they're sort of second line, third line, they're highly cardiotoxic and dangerous in overdose, and they also tend to have significant anticholinergic side effects. The secondary tricyclics, which refers to their amine structure, have fewer anticholinergic side effects than the tertiary ones, and so you can juggle that a little bit, but anticholinergic side effects do still limit their utility. Talking about monoamine oxidase inhibitors, which are only used by about 2% of psychiatrists regularly, they interact with too many things. So the thing that everyone learns in medical school they interact with is tyramine, which is found in many foods, and can cause a hypertensive crisis, because the monoamine oxidase inhibitors will inhibit your body's ability to metabolize the tyramine builds up, it acts as a sympathomimetic and causes a hypertensive crisis. That one's actually not that hard to get around because selegiline, which is a monoamine oxidase inhibitor, is now made in a patch. And so you absorb it transdermally rather than through the gut, And so your gut monoamine oxidases continue to function, and they can manage tyramine in that setting. However, it doesn't leave you anywhere near being in the clear, because monoamine oxidase inhibitors also interact with other sympathomimetics like Sudafed, or certainly like adrenaline or noradrenaline, to cause potential hypertensive crisis. And I had a case in the ICU where I had a patient who was on phenelzine, which is a monoamine oxidase inhibitor, being transferred to the ICU. And I had to tell the ICU docs that, we stopped the phenelzine, but if they had to give her pressors, it would probably turn into a really problematic situation, because she couldn't metabolize those pressors potentially. And happily that didn't actually have to be done, but everyone was pretty nervous about that in that situation. They interact with other serotonergic agents because serotonin is a monoamine, and so it's also broken down by monoamine oxidases. And so if you inhibit that, then you can have dangerously high levels of serotonin. And because of that, monoamine oxidase inhibitors require at least 2, but up to 6 in the case of Prozac, weeks of washout from other antidepressants so that they don't overlap and cause the serotonin syndrome, and similarly with sympathomimetics so that they don't overlap and cause hypertensive crises. All of which makes them very difficult to prescribe, and they're dangerous in overdose, and usually by the time I'm reaching for a monoamine oxidase inhibitor, I should be thinking about ECT. So putting it all together, right, in order to make an educated approach to picking these medications, we're going to start by saying, here's our chart from activating to sedating. We're going to get rid of paroxetine because of all the reasons we discussed. I'm going to get rid of citalopram because of the dose limitation and the cardiac concerns. I'm going to get rid of trazodone. Trazodone is a great medication for sleep, but it's just generally too sedating to be useful as an antidepressant. Sleep doses tend to be 25 to 100 milligrams. Antidepressant doses tend to be 3 to 4, sometimes even 500 milligrams, and very few patients can tolerate those doses. We can get rid of our tricyclic antidepressants in terms of the commonly used medications because they're just not safe and they have those anticholinergic effects. And organizing it now, so bupropion, just to remind ourselves, is helpful in nicotine dependence, useful for weight loss, doesn't cause the sexual dysfunction, but we do have to be aware of the seizure threshold. Venlafaxine and duloxetine are good for neuropathic pain, good for ADHD. Fluoxetine has that long half-life. Sertraline and escitalopram really don't have a lot of notable characteristics, which makes them useful. And then mirtazapine can be helpful for people trying to gain weight and doesn't have that sexual dysfunction issue. So that's kind of how I organize things in my mind. We're going to switch to do some cases. So we'll read through some cases, and then I will talk you through how I would think about approaching the selection of antidepressants. So here's the first case. We've got a 57-year-old man, no psychiatric history, who comes in for treatment of new onset panic attacks. He had a pacemaker placed for AFib with RVR that wasn't responsive otherwise, and was repeatedly shocked a month ago during an episode of arrhythmia. Since then, he's had panic attacks most nights, characterized by sweating, heart racing, difficulty catching his breath, he feels flushed, has a sense of impending doom, etc. So he has panic attacks. He avoids going out in public in evenings because he really doesn't want this to happen in public. He's been to the ED multiple times in response to these panic attacks, had EKGs that show he has no cardiac issues, his AFib is well controlled, and he's appropriately paced, right? So I'm going to pause here, and I want you to write down what diagnoses you would consider, and then I want you to write down not just what medications you would consider, but how you would pick those medications. So write down really explicitly, how would I get to the medications that I would recommend? Okay, so the diagnoses that I would consider include panic disorder and possibly an adjustment disorder. You could make an argument that he may have an acute stress disorder, but I haven't provided enough information here to actually make that diagnosis. And given those diagnoses, I would think through the algorithm like this. So the first thing, I need to locate that patient in the algorithm. So he's never taken an antidepressant medication before. He doesn't have any psychiatric history. So he is at step 1 of the algorithm. I'm thinking about SSRIs, maybe an SNRI, maybe mirtazapine, right? And so that's exactly what I would consider. So I would think about sertraline. I'm looking at, does he need help sleeping or staying awake? This doesn't seem to indicate either, so something neutral from that regard. Does he need help gaining or losing weight? Again, doesn't seem to indicate either, something neutral from that regard. No other special considerations, no pain, no substances, etc. And so sertraline would be a reasonable option. Similarly, escitalopram would be a reasonable option. I might think about fluoxetine as well. And so I think that's kind of how I would think through the algorithm. Let's do it again. For the next case, we've got a 26-year-old woman without a psychiatric history who presents for treatment of depression after her mother died. Now, it's been over a year since her mom died, but she's still struggling with frequent bouts of sadness. She's lost 15 pounds in the last 4 months, is unable to sleep past 4 a.m., getting poor performance reviews at work due to impaired concentration and memory, and feels like nothing in life is enjoyable anymore. So again, pause, write down what diagnoses you would think about, and then write down not just the medications you would consider, but how you would get to those medications. All right, so I would diagnose this young lady with major depressive episode as part of major depressive disorder. There is the condition under study of sort of pathological grief response in DSM-5, but that's still under study. It's not really been formally accepted. So she meets criteria for a major depressive episode and disorder. Now, in picking a medication, I would do the same thing. So I want to locate her on my algorithm. She has no psychiatric history, has never taken a medication before. So she's going to be at step 1, where I'm thinking SSRI, an SNRI maybe, or mirtazapine maybe. And then as I look through my options there, I'm going to say, does she need more help sleeping or being more awake? So we know that she's unable to sleep past 4 a.m., so she needs help sleeping. I'm going to ask, does she need help gaining weight, losing weight, or neither? She's lost 15 pounds. We're assuming that's unintentional here, and so she probably needs some help gaining weight back. And so that's where I'm coming from. So in picking the medication, I'm still going to consider sertraline, escitalopram, or fluoxetine, because those will ultimately address her sleep issues, help her regain her appetite, and address all the other symptoms of depression as they treat her depression. In her case, though, I'm also going to consider mirtazapine because it will more immediately address her sleep and her appetite as simultaneously treating her depression over the longer course. And so this is a good example of when I would adjust that algorithm based on symptoms that I want to target. Looking at another case, now we have a 35-year-old woman with a history of MDD presenting complaining of persistent depression despite treatment with maximum dose sertraline and escitalopram in the past. She's been depressed for over 8 months. She spends 16 hours a day lying in bed, reports she doesn't have the energy to get up in the morning, and that there's nothing she would enjoy doing anyway. She's gained 35 pounds in the last 8 months, feels like she's failed everyone in her life, and states she only leaves the house about once a week to shop for groceries. And recently, she's started hearing vague voices when she feels especially badly, although she can't make out specific words. So again, let's stop, write down the diagnoses you would think about, write down your rationale for picking the medications and what medications you would arrive at. All right, so in this case, she meets criteria for a major depressive disorder with an active current episode, and I would say rule out, rule in psychotic features with these vague voices. As I pick a medication recommendation for her, so I'm going to start by saying, where is she in the algorithm? So she has had trials of maximum dose sertraline and maximum dose escitalopram, so that would move her down to step 3, really, and which I'm going to be looking at. We really need to switch classes of medication here. I don't think it's a great idea to try another SSRI class medication. And so I'm going to then look at what other issues is she having that I could hopefully address. So we know that she is spending up to 16 hours a day in bed. So we want to help increase her energy level. We know that she's gained 35 pounds in the last 8 months, so we want to maybe help support her losing that weight. And so given those considerations, I would think about bupropion as a reasonable agent. It's going to represent a switch in class. It's going to help her with her weight potentially, and it's going to help her with her energy. I'd also think about venlafaxine and duloxetine. I would be hesitant to recommend fluoxetine, but it's the most stimulating of the SSRIs, so I suppose we could continue to consider it. Other things that we should think about. So I would consider an antipsychotic if she's having psychotic features, and I would at least be thinking about ECT given her history of medication treatment failures and the severity of her depression. And we'll finish up with one more case. So now we have a 39-year-old man with a history of post-traumatic stress disorder and depression who comes in after returning from a recent deployment to Afghanistan. He's having trouble sleeping because of nightmares about combat, can't tolerate being in crowded places, visibly jumps at small noises during your interview. His unwillingness to leave his house is exacerbated by a lower spinal injury that left him with chronic leg pain and a limp that he thinks makes him look like an easy target. He has difficulty sleeping through the night, trouble enjoying doing anything with his family, feels very guilty for the time that he was deployed, low energy concentration. He adamantly denies suicidal thoughts, though. He's tried maximum dose sertraline and venlafaxine. Neither were helpful. He's also tried mirtazapine, but found it to be far too sedating, and it also notes that it didn't work. So pause, write down your diagnoses, and write down how you would pick medications to recommend for this gentleman. All right, so in terms of diagnoses, I think he meets diagnostic criteria for post-traumatic stress disorder, for a major depressive disorder, and we should also consider his chronic pain. Now, in terms of picking a medication, we're going to look at our algorithm so we can see that he's tried maximum dose sertraline and maximum dose venlafaxine and found neither to be helpful. So those would both advance us through the algorithm. He also tried mirtazapine, but we don't know about the dose there, so I don't know that that would move us through the algorithm. So we'd be down at step 3 of the algorithm, right, in which we're looking at definitely switching classes, thinking about, essentially all of our options are on the table at that point. So the medications that I would think about are being drawn from a bigger pool. Now I want to ask, does he need help sleeping or staying awake? Well, he's having trouble sleeping at night, so something a little bit sedating would potentially be useful. Does he need help gaining or losing weight? It's not actually clear about that. Does he have substance issues? Doesn't appear so. I would look at his chronic pain and say, oh, okay, so that would suggest that we might want to think about duloxetine or a tricyclic. And so putting all of that together, I probably would consider nortriptyline or another tricyclic antidepressant. Those would help him with his pain. They would help him sleep. We know that he's adamantly denying suicidal thoughts, and so I'm not too worried about him overdosing. And they would represent a switch in class from sertraline and venlafaxine. I might try duloxetine. It's not a class switch from venlafaxine, but it does have the overlap with pain, and so it might be helpful in that regard. We could try escitalopram. And then the other thing I would mention is we should probably think about prazosin to help him with his nightmares. So we're going to stop here with the talk about antidepressants. I hope that we've succeeded in our goal, which is to help you to be able to sort of understand why we pick antidepressants the way that we pick them, and for you to have your own approach that makes sense for you to pick antidepressants when you're making recommendations to patients. So just to reiterate, antidepressants all have roughly equal efficacy. And so the way that I recommend picking them is we have an algorithm that's largely based on safety considerations. And then we're going to adjust that algorithm for side effect profile. And so the algorithm is going to require therapeutic failures to progress from step 1 to 2 to 3 to 4 in the algorithm. And the side effects that we're going to look at include whether the patient needs help sleeping or being awake, with more or less appetite, chronic substance use issues, ADHD, anxiety issues. We're going to look at chronic pain, at headaches, and consider sexual side effects and seizures. So those are all the things that I'm thinking about when I'm making antidepressant recommendations for my patient and trying to put those all together in order to make a logical choice of what I'm going to recommend. I hope this is helpful. Before we move on to discussing the treatment of bipolar disorder, I want to encourage you to take a break. Go do something fun, take a few hours off, let your mind kind of recover from what I know is a pretty dense amount of material to learn. That said, hoping you've done that, let's move on. So when we think about treating bipolar disorder, the first thing we need to understand is that bipolar disorder is probably the most frequently misdiagnosed illness in psychiatry. So it is both the most commonly overdiagnosed illness, people who don't have it being diagnosed with it, and the most underdiagnosed illness in that people who do have it aren't being identified. So we need to diagnose bipolar disorder correctly before we're going to be able to treat it appropriately. And in thinking about how to diagnose bipolar disorder, I really want to focus on bipolar 1 disorder. So what we're looking for, the heart of making a bipolar 1 diagnosis, is mania, a full manic episode. So anyone who has a full manic episode in the absence of drugs or medical explanations automatically has bipolar 1 disorder. So we need to ask, how do we diagnose a full manic episode? And the first thing that I would say is that when I went back and looked, I learned that the single most sensitive symptom of mania is a sleep disturbance, and it's only about 50% sensitive, which can make it difficult for your patient to describe accurately a history of mania. Making it even harder is the fact that many bipolar patients have trouble remembering their manic episodes, especially when they're depressed. So often if you're asking someone who feels like there's no hope, they've never felt good, etc., about when the last time they felt really great was, they're going to say, oh, it's never happened, and that may or may not be accurate. So we need to think about getting collateral to confirm a bipolar diagnosis, unless your patient clearly describes mania or is clearly acutely manic. So my general approach is that if I have a patient who comes in with depression, and I'm trying to figure out whether they have bipolar depression or unipolar depression, I'm going to look at my pretest probability. So if I have no evidence that they have bipolar disorder, then I'm probably going to simply ask them, have you ever had a period of time where for days or weeks on end, you didn't sleep because you didn't need to sleep? Why bother sleeping? You had tons of energy or were just so irritable, you didn't need sleep. And if they say no, then I'm probably just going to drop it there. If my pretest probability is higher, though, for some reason, there's a chart note referencing bipolar disorder, they have a previous diagnosis, family members are describing bipolar-like symptoms to me, then I'm probably going to try to get collateral because I'm going to acknowledge the fact that the sensitivity of those screening questions isn't super great and the memory of patients during the period of time when they're acutely manic isn't super great. And so I may try to look for family members or try to look for past chart notes that more clearly describe symptoms, etc. The last thing I want to talk about is stop, pause, and write down a description of what rapid cycling bipolar disorder is. All right, so what rapid cycling means is 4 discrete mood episodes per year. The reason I bring this up is that we often have people being diagnosed with bipolar disorder because they're happy in the morning and sad in the afternoon and happy again in the evening. That's not bipolar disorder, or it's very unusual for that to be bipolar disorder. That's much more consistent with someone who simply doesn't have the coping skills to regulate their moods, right? We see that kind of mood lability in children all the time because they don't have the coping skills to regulate their moods yet, and we consider that normal in children. So if you have someone who's coming in and describing those kind of mood changes, despite the fact that they are technically visiting both poles of being very happy and being very unhappy, what we're really looking for to make a bipolar disorder diagnosis is episodic periods of depression and of mania. So that's more consistent with mood dysregulation. So having made the diagnosis of bipolar disorder, we now need to start thinking about treating bipolar disorder. And to understand the treatment of bipolar disorder, we have to understand that it's really a matter of managing 4 different situations, all of which fall under the bipolar spectrum. So the first of which is managing acute mania, managing acute depression, and then prophylaxing against manic episodes in the future and prophylaxing against depressive episodes in the future. Furthermore, I'm going to argue that you have to consider all four of these situations when you're treating your patient with bipolar disorder, and here's why. So I want you to stop and ask yourself, what percentage of people with an acute manic episode today that then resolves will go on in the future to have another major mood episode that requires treatment? So one study found that following a first manic episode, recurrence following remission occurred in 58% of patients by 1 year, 74% by 4 years, and if you looked out further, approaching 90 to 95% of patients. And of those recurrent mood episodes, 60% were depressive, 28% manic, and 12% hypomanic. Another study, this is actually a meta-analysis that looked at 6 different studies of patients with bipolar disorder, and what we can see on the right here is that the green bars represent the percentage of the patient's total life spent manic, the percentage of the patient's total life spent depressed, and the total amount of their life which they spent in a major mood episode of one kind or the other. And what we see here is, looking down at the bottom chart, the total percentage of time that a patient with bipolar disorder will spend in a major mood episode is greater than 50%, 54% in this study, and that although it varies from study to study, if we look at the ratio of those red bars to the green, so here's where we're going. This is the list of medications that I think of when I'm treating patients with bipolar disorder, and those include lithium, olanzapine or Zyprexa, quetiapine or Seroquel, aripiprazole or Abilify, lorazepam or Latuda, lamotrigine or Lamictal, risperidone or Risperdal, and plus or minus valproic acid or Depakote. So the goal of this is to logically arrive at this list, for you all to understand how I came up with this list and how this list would be most appropriately applied. So this is a list of other medications that we see sometimes used in bipolar disorder, that I've seen used in bipolar disorder, that have limited or no utility in that illness, and that list includes our typical antipsychotics, carbamazepine, oxcarbazepine, topiramate, and, as we'll discuss, antidepressants. So in order to arrive at this list in a logical way, let's discuss how to actually stabilize the bipolar moods. So we know that the list of mood stabilizer medications is very long, and we again need a way to sort through them logically. So we're going to return to this question of what is the most important factor in picking a medication to treat any condition. And as with the antidepressants, the answer is efficacy first. And unlike the antidepressants, not all medications that we use to treat bipolar disorder are equally efficacious. Furthermore, each of the 4 situations, acute mania, acute depression, prophylaxis against mania and depression, calls for a different approach. And we're going to start with treating acute mania. So acute mania is probably the easiest of the 4 phases of bipolar disorder for which to pick a medication, primarily because it's the most studied of the 4 phases of bipolar disorder. So we'll talk here about 3 options, but it's worth knowing that many more options are effective in the treatment of acute mania. So this is a study that looked at 2 different Depakote dosing titrations in the purple and the green. It looked at olanzapine at 10 milligrams a day in the blue, and at lithium in the yellow, and compared them with placebo. The y-axis is our mania rating scale, so the further you fall on this, the more effectively we have treated your mania, and the x-axis is time, of course. So what we see here, lessons from this, are that acute mania responds well to olanzapine, valproic acid, and lithium, right? They all came down nicely. That some patients is actually required, since aggressive treatments still take about 7 days before they even begin to separate from placebo, let alone adequately treat the mania. So what we see if we look back at the graph on the previous slide is that the asterisks denote statistical significance, and that you have statistically significant separation from placebo at day 7 for olanzapine and the more aggressive of the Depakote titrations, and then at day 10 for lithium, and then olanzapine and the more aggressive of the Depakote titrations. If we follow it out a little further, that purple line will also become statistically significant. It just takes longer with that particular Depakote titration to get there. Because of that, if you're using valproic acid or Depakote, I'd consider a loading dose-based regimen, the one in green. And it's worth noting here that although it's beyond the scope of this lecture, treatment with multiple medications is evidence-based in the setting of acute mania and is frequently what we use. As I mentioned, there are multiple other medications with an evidence base for the treatment of acute mania, and those include carbamazepine or Tegretol, oxcarbazepine or Trileptal, all of the atypical antipsychotics essentially, the typical antipsychotics, and various combinations of the things listed above. Really, the only two medications that have been historically associated with bipolar disorder that don't have efficacy in acute mania are topiramate, which really doesn't have efficacy in any of the phases of bipolar disorder, and lamotrigine, which simply takes too long to titrate up to an effective dose for it to be a reasonable treatment for acute anything. So remembering that there's a very high rate of recurrent mood episodes, we need to consider prophylaxis. And when we look at prophylaxis against mania, we realize that mania is easier to treat than it is to prevent, and that there are relatively few head-to-head comparisons for maintenance treatment options. That said, essentially the same medications that work for treating acute mania also work for preventing future manic episodes. Lithium is kind of the standout here. It really has the best support for prophylaxing against mania, and studies suggest that it actually works better than other options, specifically for preventing classic manic episodes. There's also good data that atypical antipsychotics work well in preventing manic episodes, and there's some data that suggests that valproic acid, carbamazepine, and oxcarbazepine have mixed episodes supporting their prophylactic efficacy. Moving on to the treatment of acute bipolar depression, the first logical question would be, can we use antidepressants to treat this flavor of depression? And unfortunately, it's not terribly well studied, but the answer is probably no. So I would be showing you graphs if I had them, but there really isn't a lot of evidence base to answer this question. So based on expert opinion, we can see, and I'm not going to read all of these, but essentially that expert opinion agrees that there isn't convincing evidence for the use of antidepressants as monotherapy in the treatment of acute bipolar depression. So I'll read this last one, which was written by the International Society for Bipolar Disorders Task Force report on antidepressant use, which sounds very convincing. It seems like they would know if anyone does, and they suggest that available clinical trials do not produce adequate support for the efficacy of antidepressant monotherapy in acute bipolar depression. While acknowledging that the evidence base is poor and inconclusive, they recommend that antidepressant monotherapy should be avoided in bipolar I disorder. It would be reasonable then to ask, what about using antidepressants as an adjunct, as an augmentation agent to other mood stabilizers? And there is a study that looked at that. And this is what we see. So we find in terms of all of these different outcomes, including remission, durable recovery, treatment effectiveness and response, and affective switch, etc., there is no significant improvement when you compare mood stabilizer plus antidepressant regimen to mood stabilizer plus placebo regimen. And therefore, the evidence for antidepressants as adjunctive treatment is negative, although frankly this is the only study on it, and I wish that there was more data. So understanding that antidepressants are not an appropriate treatment for bipolar depression, it's reasonable to ask, when would we use antidepressants in bipolar patients, which we do all the time? And the answer is, again, not for depression, but take a pause now and write down why you think we might use antidepressants in treating patients with bipolar disorder, knowing that we would not use antidepressants to treat their bipolar depression. So the answer is for the treatment of comorbid conditions, typically anxiety disorders, which are frequently comorbid with bipolar disorder. And there's a small risk of switching a patient into a hypomanic or manic episode, so we only would want to use antidepressants in patients who already have a mood stabilizer on board and whose mood is relatively stable. They should be generally avoided in patients with high instability with rapid cycling, or in patients with predominantly mixed states because of this risk of switching them into a major mood episode. So having determined that antidepressants aren't an effective treatment for bipolar depression, we need to ask what is. And it's a shorter list. So a list that includes atypical antipsychotics, particularly quetiapine, olanzapine, and lurasidone. Lithium, which is less effective in treating depression than it is at treating mania, but is still as effective as any other agent in treating bipolar depression. Possibly carbamazepine and valproic acid, although the evidence for these agents is poor. It's always worth remembering ECT, which is effective for bipolar depression and for mania in refractory cases. Finally, we need to remember the importance of prophylaxing against bipolar depression, because that is one of the highest risk things that people are going to be exposed to. Unfortunately, the evidence base for prophylaxing against bipolar depression is probably the poorest of any phase of bipolar disorder, and also the list of effective medications is the shortest, and so those include lamotrigine, which again requires too long a titration to be a reasonable treatment for acute bipolar depression, but can be effective at preventing future bipolar depressive episodes. The atypical antipsychotics, including quetiapine, lurasidone, and olanzapine especially. Lithium, which is better at preventing manic episodes than depressive episodes, but still effective at preventing depressive episodes. And really, that's about it. So how well do our prophylactic agents work? Unfortunately, not nearly as well as we'd like. This is data from a population-based United Kingdom cohort study in which they reviewed medical records and compared valproate, lithium, olanzapine, and quetiapine, and looked at how long it took for that medication to need to be stopped or another medication to need to be added as a proxy for how long it took for them to have a significant psychiatric mood episode. It looked at about 5,000 patients, and there were roughly equal numbers on each medication, and what they found is here. So the rate of a major mood episode per 100 person years for people on lithium was 73. For those on valproate was 116, on olanzapine was 109, and on quetiapine was 177.9. So it depends on how you adjust it, but using lithium as a baseline, we can see that lithium was probably the best of the four agents, olanzapine the next best, then valproate, and then quetiapine. If we actually look at the average time to a major mood episode, which I'm not presenting here, but I happen to know off the top of my head, it took about 2 years for treatment failure with lithium, and it took about 9 months for treatment failure with quetiapine, and valproate and olanzapine fell somewhere in between. And so putting it all together, we know that these patients are at significant risk of major mood episodes that we need to try to prophylax against. But even our best agents at prophylaxis, things like lithium and our atypical antipsychotics, really only prolong the next major mood episode for a year or two, which is still significantly better than placebo, but not nearly as well as we would like. Turning to review the individual medications, let's start with lithium. So lithium is first the only medication demonstrated to decrease suicide rates in bipolar patients, although another study suggested that valproate may do the same thing. Lithium has a lot of immediate side effects because essentially the therapeutic dose range overlaps the toxic dose range. And so the side effects that people experience when taking lithium include sedation, weight gain, cognitive blunting, which is the primary cause for discontinuation. Can cause significant nausea and potentially vomiting. The extended release is less offensive in that regard. Because it's a salt, and like any salt, it's going to increase water movement through the kidneys. It's going to cause polyuria and increased urinary frequency. It's worth noting that it can cause a benign AV block. So if you're checking an EKG on a patient who's taking lithium and you notice a first or second degree AV block, it's probably benign. It can also cause a benign leukocytosis. And before the development of GCSF, lithium actually used to be used in cases of neutropenia to help boost people's white counts. And lithium causes a fairly significant tremor in some cases. Lithium also causes a slew of long-term side effects in various organ systems, and those include two effects on the kidneys: nephrogenic diabetes insipidus and renal failure, chronic renal disease. And so the nephrogenic diabetes insipidus is separate from the chronic renal disease, and it's worth remembering. People often think that the nephrogenic DI causes the renal failure, but they're two separate processes. The actual nature of the renal failure is poorly characterized because it's rarely biopsied in the setting of lithium, because lithium is so easy to attribute the renal damage to that they don't go looking for histopathology. But we do know that it can cause damage to the tubules and the glomeruli in various different ways, independent of the nephrogenic diabetes insipidus, and that it can lead to end-stage renal disease and dialysis dependence over a long enough period of time for some patients. Lithium also causes fibrosis of the thyroid gland and ultimately can cause failure of the thyroid gland, and it can cause failure of the parathyroid gland as well. Because of these effects, we monitor multiple different parameters during lithium treatment, the first of which is the lithium blood level itself, which should generally be maintained in the 0.7 to 1 range. But we also want to monitor patients for their renal function, for their thyroid function, and for their calcium as a marker of parathyroid function. Lithium toxicity is another important topic for us to discuss, primarily because it's very common, so you're almost certain to see it working as a physician. And that's because lithium has, as we said, no real therapeutic window. There's a lot of overlap between the therapeutic dose and the toxic dose. And because it's renally processed, lithium toxicity can be caused by essentially anything that significantly affects renal function, and that can include medications like diuretics or NSAIDs or ACE inhibitors. It can include any kind of state that might cause dehydration, including reduced fluid intake, significant exercise, or even very hot weather in some circumstances. And of course, lithium itself over the long term can affect renal function. And so if you're not monitoring renal function in a patient who's on chronic lithium treatment, it is entirely possible that what used to be a therapeutic dose could become a toxic dose as their renal function declines. For all these reasons, unintentional lithium toxicity is quite common and is actually the most common form of lithium toxicity. That said, intentional lithium toxicity in the setting of overdose is also fairly frequent, and that's because bipolar disorder patients have about a 25% chance of attempting suicide, and unfortunately about a 12-ish% chance of completing or dying by suicide. So knowing that, we need to understand how to address lithium toxicity. And the first thing to understand is that the level of toxicity is related to multiple different parameters, and those include the absolute blood level, but also the chronicity of lithium use, the formulation, and the renal function. The blood level is fairly straightforward. It's the number that you get on the lab. But the chronicity of lithium use requires some attention. So this is important because lithium takes about 24 hours to equilibrate across the blood-brain barrier. and of all of the various effects of lithium toxicity, which include significant GI distress, significant worsened tremor, potentially non-benign EKG changes, which can be fatal, but are very unlikely to be fatal. Also includes potentially acute renal failure, which again is unlikely to be fatal and is generally recovered in a patient who's in the hospital and can get access to treatment and dialysis if they need it. The most dangerous part of lithium toxicity is its effects on the central nervous system, which can include seizures, coma, and ultimately death. And because lithium takes 24 hours to equilibrate across the blood-brain barrier between the blood level and the CSF level, and because the symptoms that we're most worried about are those that happen in the central nervous system, the chronicity of lithium use is very important. So when we think about it, we consider there to be three different chronicities of use. The first is what we call acute poisoning, and that's when you have someone who's lithium naive and then takes a bunch of lithium. So the classic case example would be a 5-year-old who gets into their parents' medicine cabinet, takes a bunch of lithium, and comes into the hospital. Because it takes 24 hours for that lithium that's in their blood now to equilibrate across the blood-brain barrier, and because presumably they're still processing the lithium in their blood, the actual dose that their brain is going to see is significantly lower than the blood level that you're going to detect when you check it. And so it's actually quite rare for there to be serious outcomes from acute lithium poisoning. The next level of lithium poisoning is what we call acute on chronic lithium poisoning, and that's a patient who is typically at a therapeutic lithium level and then has lithium poisoning on top of it. The classic case example for that would be a patient with bipolar disorder taking lithium who overdoses on lithium, generally intentionally. As we might expect, their CSF lithium level is already going to be elevated at a presumably therapeutic level between 0.7 and 1, and then their blood level is going to spike even higher than this. Because there's no therapeutic window, they're at significantly higher risk of having too high a CSF level and having more significant neurologic sequelae. And then the most dangerous of the forms of lithium poisoning is chronic lithium poisoning, and essentially that's what's happening when you have someone whose renal function has been affected to the point that their blood level of lithium creeps up slowly over time, and as a result, their CSF level of lithium creeps up slowly over time. And so when it's finally detected, whatever blood level they're at, that is also the CSF level that they're at. And predictably, neurologic outcomes from that are the most severe, including the highest rates of coma and death from lithium toxicity. So we finally need to consider the formulation of lithium that the patient's taking, because lithium comes in different forms, and the extended release version is kind of notorious for forming what's called a pharmacobezor, which is just a ball of pills, but it results in really unpredictable absorption rates in the GI system. And so you, particularly in the setting of someone who has overdosed on extended release lithium, need to be chronically monitoring their blood level until you're sure that it's stabilized at a relatively stable point. Lithium was also category D in pregnancy due to an increased risk of Epstein's anomaly. Although more recent studies dispute the severity of this risk, it is accepted to increase your risk of Epstein's anomaly. The initial studies suggested by maybe 100-fold, although more recently the studies suggest that it's maybe by more like 2-fold. And because pregnancy is a state which involves a lot of fairly significant fluid shifts, lithium treatment certainly can be continued during pregnancy, but we would recommend that be under the supervision of a psychiatrist and that the delivery be performed in a hospital where a consult psychiatrist is available. Turning our attention to valproic acid, or Depakote, it's important to remember that valproic acid is effective at the treatment of acute mania and possibly at prophylaxing against mania, less effective at the treatment of acute bipolar depression, and really not an evidence-based prophylactic agent in terms of preventing bipolar depression. So the common side effects that we see with valproic acid are many and include somnolence, significant weight gain, hyperammonemia, nausea, and vomiting, with an average weight gain in young women of 22 kilograms or more than 45 pounds, so that's obviously quite significant, and an average incidence of hyperandrogenism in young women of 85%, with a 10% incidence of new onset full polycystic ovarian syndrome. So this is a medication that's very toxic in young women, as well as just being toxic in general. Valproic acid carries a risk of potentially fatal hepatotoxicity, as well as a risk of chronic hepatotoxicity. It carries a risk, a very rare risk, but a risk of potentially fatal pancreatitis. It causes bloodline dyscrasias, most notably thrombocytopenia, and because of all that, it requires monitoring of the valproic acid level with a target range of 50 to 100, but also CBC and LFT monitoring to look for end organ effects. Valproic acid is dangerous in overdose, can cause heart block, coma, and potentially death, and it was considered Class D in pregnancy. Unlike lithium, the evidence around the toxicity of valproic acid to the fetus is quite clear. It increases the risk of spinal cord anomalies like spina bifida significantly. Baseline risk of major fetal malformations, defined as those requiring surgery, is about 3%. In patients taking significant high doses of valproic acid, that risk rises to about 10%. Even in patients who don't develop spina bifida, there is significantly increased risk of lower IQ. So the average IQ in the United States is 100. It's benchmarked at 100. In babies born to mothers taking lithium, the average IQ is 93. And there's clear evidence for multiple other neurodevelopmental problems, including autism at higher rates, ADHD, depression, anxiety, etc. So valproic acid should be clearly avoided in any woman of reproductive age who is not on a demonstrable, permanent, or semi-permanent form of birth control, by which I mean tubal ligation, an IUD, Implanon, or Depo-Provera. Turning now to carbamazepine or Tegretol, which again is an effective treatment for acute mania, but not an evidence-based treatment for prophylaxing against mania or depression in the setting of bipolar disorder, and therefore is not very high on my list of medications to use in bipolar disorder, although it was considered a gold standard medication for some years, and that's why we'll discuss it in a little more detail here. So carbamazepine is an inducer at CYP3A4, which is probably the most active of the isoenzymes when we're thinking about medicine in general, and therefore it interacts with a long list of other medications. It carries a 1 to 6 per 10,000 risk of Stevens-Johnson syndrome and potentially toxic epidermal necrolysis, except in the Asian population where patients with a certain major histocompatibility complex are actually at about 100 times higher risk. And so if you're using carbamazepine in a patient of Asian descent, it's essentially standard of care to test for this particular histocompatibility complex. Carbamazepine also carries a low risk of aplastic anemia, about 5 to 10 times the baseline rate, but still only a few cases per million patients per year. So very low risk, but very severe outcome. It can cause liver damage. It also requires blood level monitoring with a target range of about, I think of it as being about 7 to 10. Patients also need CBC monitoring and LFT monitoring. It was also considered Class D in pregnancy, associated with an increased risk of spinal cord anomalies, although subsequent studies have suggested that that increased risk is probably not very significant and that it may have been just sort of painted with the same brush as valproic acid. The risk of taking carbamazepine in pregnancy is actually significantly lower than it was previously suspected to be. It's unclear if that risk is 0 or if it's somewhat elevated. We just don't have the data to answer that question. Looking at lamotrigine or Lamictal, which is a medication that we think of exclusively in the prophylactic phase, but is effective at prophylaxing against both mania and depression. We know that it's generally well tolerated. It can cause some GI upset, some headachiness, those sorts of things. But the one significant side effect that was that of Stevens-Johnson syndrome. The absolute risk of Stevens-Johnson syndrome is quite low at about 1/10 of 1%. But we know that the risk is related to the rate of dose increase, and so a very slow schedule is required. It starts at 25 milligrams every other week. You can gradually accelerate the rate of increase. There's clear guidance on micromedics or up-to-date, etc., so I refer you to that. But it is this slow titration that makes it a really not an appropriate medication to use in the acute phase of any illness. It's also worth noting that the risk of a rash in patients taking lamotrigine is about 10%, and we know that the risk of that rash being Stevens-Johnson syndrome is about 1%, so the overall risk of Stevens-Johnson syndrome being 0.1%. That said, we will appropriately overreact to every one of those rashes in order to catch that rare Stevens-Johnson syndrome, because it is impossible to know beforehand which rashes will turn out to be potentially fatal. So going back to our principles and trying to come up with a logical approach to picking medications in bipolar disorder, assembling all that we now know, we want to remember that almost all bipolar patients, bipolar 1 patients, will have major depressive episodes. Bipolar 2 patients definitionally have a major depressive episode. And we want to remember that bipolar patients will spend, on average, more time depressed than manic, that you will often meet your patients in the midst of a manic episode, particularly if, like me, you work in the hospital, because mania is dramatic and it comes to medical attention. And we know that there are a lot of options that we could use to treat acute mania, but I would argue that we should pick a medication to treat their acute mania or their acute depression now that we can ultimately continue them on in order to prevent future episodes of mania or depression down the road. So putting it all together and trying to come up with a logical approach to treating bipolar disorder based on what we've discussed, this is kind of what I've come up with. So these are our options that we can use to treat acute mood episodes and are effective at preventing future mood episodes. And those include lithium, our atypical antipsychotics, specifically quetiapine, lorazepam, and olanzapine. Potentially lamotrigine in the long term if we're focusing on the prophylactic element. And then combination therapy like we discussed. It's worth noting in terms of the typical antipsychotics, there's decent evidence that while they are effective treatments for acute mania, they increase the risk of flipping immediately from mania into depression, and they also, over the long term, increase the risk of your bipolar patient going into major depressive episodes. So I generally avoid typical antipsychotics in the treatment of bipolar patients. Understanding that, let's look at a case. So we've got a 28-year-old man with no psychiatric history who comes into psychiatric emergency services after setting his car on fire, saying that it was a signal to God of his devotion and that God will provide him with a new car, a better car. He has been sleeping poorly for a couple weeks, but in the last 5 days he stopped sleeping entirely. He has, however, visited every casino within 200 miles and tells you that God is guiding him toward a big score. He usually works as a legal assistant, but simply stopped showing up a week ago, about which he's unconcerned, telling you that he now makes enough money and has enough money saved up to buy the whole hospital. He reports that God is talking to him during your interview and spends 5 minutes saying seemingly random things, telling you that he's acting as the mouth of God. And it takes you over an hour to extract yourself from the interview room because he's so difficult to interrupt. Before you go, he insists that you pray with him. So what diagnoses would you consider? So pause here. Take a minute, write down the diagnoses you would consider and the medications that you would consider and why. So I think the first thing we need to rule out in any case like this is substance intoxication. This could easily be a presentation of stimulant intoxication, but I'm going to tell you that his UTOX is negative. So the other thing we would think about, of course, is acute mania. And when I'm thinking through this case, I would think about olanzapine, risperidone, quetiapine. I'd think about lithium. And I'd think about Depakote with a loading dose-based regimen. Depakote would probably be on the bottom of that list because, again, of these options, the first two are things we could potentially consider continuing over the long term in order to act as prophylactic agents as well, whereas Depakote, the evidence base for that is somewhat less good. The patient, of course, refuses medications because he doesn't feel like there's anything wrong with him, but is involuntarily detained as a danger to himself and to others, and you admit him to the inpatient unit after giving him a one-time dose of olanzapine. A week later, you finish your night float, and you take over the inpatient team on which he's a patient, conveniently. He's now taking medications voluntarily, largely in an effort to convince you that he's ready to leave the hospital. However, he's still only sleeping 2 to 3 hours a night, is still hearing the voice of God, and is quite difficult to interrupt. The resident on service before you started him on valproic acid, which he's now been on for 5 days. So given this clinical situation, take a minute, pause, and write down what you would do next. So the first thing we have to answer is he ready to leave the hospital? To which I would say quite clearly no. He may be trying to convince you that he's ready to leave, but he's still only sleeping a couple hours a night, is still hallucinating, and is still pressured. So you could reasonably wait, right? So we know that valproic acid takes, depending on the regimen, at least 10 days to separate from placebo and potentially longer, at least 7 days to separate from placebo and potentially longer, and certainly longer to actually adequately treat the mania. You could also consider augmenting with lithium, olanzapine, risperidone, or quetiapine. As I said, treatment with multiple agents is fairly common and is certainly evidence-based in acute mania and bipolar disorder in general. So given that, he stabilizes over the next couple of weeks on a regimen of valproic acid, lithium, and clonazepam, and is ultimately horrified to hear about what he did while he was manic. He asks you whether he'll need to take these medications for the rest of his life, and so think about what you would consider peeling off and in what order, and ultimately how you would answer his question. So I would consider removing the clonazepam first. It's not an evidence-based treatment for bipolar disorder itself, although it is frequently very appropriately used in the management of acute mania to help the patient sort of tolerate being manic in a confined setting and to help them sleep, which is a very helpful thing in terms of reducing the time that they spend manic. So I'd get rid of the clonazepam first, and that would leave him on the combination of lithium and valproic acid. And then over time, probably months, I would consider taking him off of the valproic acid and leaving him on lithium monotherapy, because we know that that's an evidence-based prophylactic agent. We also remember that our most evidence-based prophylactic agents are less good than we would like them to be, though. So this poor guy, you decide to pick him up as a clinic patient, and he's doing well after discharge for 8 months, but then starts missing appointments, and when he finally comes in, you realize that he's becoming depressed. So he's now on lithium monotherapy, and he's going into a depressive episode. What medication options would you recommend to him now? So I would think about augmentation or a switch to lorazepam, to olanzapine or quetiapine, because those are all evidence-based treatments for acute bipolar depression. And potentially augmentation with lamotrigine, depending on how severe his depression is. If we feel like we have the time to wait for lamotrigine to kick in, it might be a reasonable thing to do, although I would certainly lean toward the first of these options. All right, so now we're going to turn our attention to antipsychotics. And again, before we jump into this new section, I encourage you to take a break, go take a walk, do something enjoyable, give your mind a little bit of a rest before you jump into a whole new section of fairly dense material. That said, getting started, the objectives with the antipsychotics are a little bit different. In general, we still want to understand their efficacy, we want to understand their side effects, their formulations, and to think about how we would pick an antipsychotic to recommend to a patient, but it's a little bit less algorithmic than our approach to picking antidepressants or medications for bipolar disorder. And so as we walk through, we'll think about how best we can understand these medications. But first, we again want to ask ourselves, what conditions are we appropriately treating with antipsychotics? So I encourage you to pause the video, grab a piece of paper and a pen, and write down the indications for antipsychotics that you're aware of. All right, So those would include schizophrenia, schizoaffective disorder, all the various flavors of schizophreniform disorder, etc. Bipolar disorder, as we just discussed, antipsychotics, atypical antipsychotics, are some of the best studied medications in bipolar disorder today. We use antipsychotics as augmentation agents in treating refractory unipolar depression. We use them to treat the psychosis associated with severe mood states, such as depression with psychotic features or mania with psychotic features. They're used to treat delirium, although they don't treat the delirium itself, but they do help manage the symptoms of delirium. They are FDA approved for treating aggression in autism, specifically risperidone and Abilify, aripiprazole now. They're used to treat aggression in dementia, which we'll talk about in more detail later, and possibly aggression in other brain injury type states. So before we go through all the work of thinking through these antipsychotics in a lot of detail, it's probably worth asking whether we need to. Is the list of antipsychotics as overwhelming as the list of other psychiatric medications? Do we need to have a rational approach to recommending them? And I would argue that the answer is yes. So there's lots of antipsychotics, lots of atypical antipsychotics, and more coming out every few years, and then literally dozens of typical antipsychotics. And so we do need some reasoned approach to understand these medications. As with all the other medications that we've discussed, we're going to look at antipsychotics in terms of efficacy and side effects, and that we're going to start by looking at efficacy first. So in terms of efficacy, this is a forest plot from a recent meta-analysis that compared various antipsychotics in placebo-controlled trials. Now, the placebo is the zero line on the far right there. So the first thing that we can see is that all of these medications outperform placebo in a significant way. The second thing that we can see is that they kind of fall into three different categories. The first of which is clozapine, which is clearly superior to other antipsychotics at the top there. The second category includes amisulpride, olanzapine, and maybe risperidone. And then the third category is sort of everything else, Haldol, quetiapine, aripiprazole, etc., going down. Based on that, we would believe that clozapine is the most efficacious of the antipsychotics, that olanzapine and risperidone may be the second most efficacious, and that sort of everything else is relatively equally efficacious. It's worth knowing that amisulpride is a European agent, and that's why we don't really talk about it much here. This is from the CATIE study, which is another one of the landmark National Institute of Mental Health funded studies from the late 90s and early 2000s. It did not include clozapine, and so that's why clozapine isn't on these graphs, but it did include olanzapine, perfenazine, which is a typical, risperidone, quetiapine, and ziprasidone. And what we can see here, the outcomes that the CATIE study evaluated for are all-cause discontinuation, and then on the right we have discontinuation due to lack of efficacy. And we see in both of these that olanzapine outperformed all of the other antipsychotics assessed, and that all of the other ones were relatively equal. So the summary of our understanding of the efficacy of the antipsychotics is that clozapine is the most efficacious of the antipsychotics. There's really no disagreement about that. That olanzapine is the second most efficacious, and maybe risperidone, and that other than that, there are small or unclear differences between the other antipsychotics, to include no real difference between the typical antipsychotics as compared to the atypical antipsychotics. It's worth noting that studies do suggest that atypical antipsychotics are better, statistically better, at addressing the negative symptoms of schizophrenia than typical antipsychotics, but a more detailed analysis suggests that although there is a statistical difference, it is clinically not a meaningful difference. And so in terms of selecting a medication, that's actually not worth considering in your algorithm. Moving on to side effects. So there are three major classes of side effects associated with antipsychotic class medication. The first is dopaminergic side effects. The second, metabolic, which tracks with histamine receptor antagonism, so some people think of them as antihistaminic side effects, and the third is anticholinergic side effects. Typical antipsychotics generally involve a balancing act between dopaminergic side effects and anticholinergic side effects, while atypical antipsychotics generally involve a balancing act between dopaminergic side effects and metabolic side effects. So in order to better understand the side effects we might anticipate, we're going to go through by each category, starting with dopamine. So I want you to stop and write down now, what are the 4 pathways of dopamine in the brain, and what do they do? Okay, so the first pathway that we'll talk about here is the mesocortical pathway, which may be involved in the negative symptoms of schizophrenia. The second one is the mesolimbic pathway, which may be involved in the positive symptoms of schizophrenia. And the last 2 are the tuberoinfundibular pathway and the nigrostriatal pathway, which are going to be important to our understanding of the side effects of antipsychotic medications. We'll start by talking about the tuberoinfundibular pathway. So, like I say here, there's nothing fun about a dysfunctional tuberoinfundibular pathway. I want you to stop again and write down, what does dopamine do in the hypothalamus, and what is the downstream consequences of that? So in the hypothalamus, dopamine inhibits prolactin release. And so if you block dopamine's activity, you're going to have increased prolactin release. What are the consequences of too much prolactin? So the consequences generally map to hormonal side effects and then osteoporosis, as we'll talk about. So they include amenorrhea, anovulation, infertility, galactorrhea in women, gynecomastia in men, a loss of libido, various forms of sexual dysfunction, including vaginal dryness, erectile dysfunction, anorgasmia at rates as high as 40%. And then, as I mentioned, osteoporosis over the long term, which is why, although there are no formal recommendations about it, I consider checking a DEXA scan something that I would want to do for anyone who's on long-term antipsychotic treatment. All right, in terms of the second set of dopaminergic side effects, we need to turn to the nigrostriatal pathway. And so, what does the nigro part of nigrostriatal refer to? So it refers to the substantia nigra, part of your brain, right? And what does the substantia nigral dysfunction cause? So if we think about Parkinson's disease, dysfunction of the substantia nigra causes motor dysfunction that doesn't involve the primary motor cortex or projections from it that run through the medullary pyramids. And thus, this dysfunction is called extrapyramidal. And the symptoms associated with this dysfunction with antipsychotics and some other medications are called extrapyramidal symptoms. Now, I learned about extrapyramidal symptoms through the, quote, rule of 4s, which is largely fictional, but still somewhat helpful, right? So the first thing we're going to think about is what extrapyramidal symptom appears at around, quote, 4 hours. So stop, pause, write down the name of the symptom, write down a description of that, and then write down how we would treat it. Great. So the symptom is called an acute dystonic reaction, and it's characterized by either spastic or prolonged sustained cramps in the face or neck most commonly. They're often painful, and they're rarely subtle. It actually occurs generally during the first 24 to 48 hours of starting a medication or increasing the dose, often within 40 minutes of taking the medication, essentially as soon as it's orally absorbed and starts to kick in. The treatment for an acute dystonic reaction is generally one of 3 options, so an antihistamine like Benadryl, an anticholinergic agent like benztropine or trihexyphenidyl, or benzodiazepine. Now, the way that these work is somewhat understood. So anticholinergic agents is understood fairly well. they restore the balance between acetylcholine and dopamine in the substantia nigra, thereby relieving the symptoms of extrapyramidal dysfunction, which is also why we use anticholinergic agents in the treatment of Parkinson's disease. The antihistaminic agents, it's somewhat less well understood, although some of their activity is also anticholinergic, and that probably contributes to them being helpful. And the benzodiazepines is not terribly well understood why it relieves these symptoms, but it does. Now, which of the extrapyramidal symptoms happens next in the progression? And I learned it as 4 days, although we'll take a look at that time course. So again, I want you to pause, write down the name of the symptom, characterize the symptom, and write down how you would treat the symptom. So that symptom is akathisia, which is an intense sense of internal restlessness. Now, this isn't a tolerable sensation. If you see patients who are akathetic, they look like they're just climbing out of their skin. It's very uncomfortable. It generally occurs within a few days of taking the medication, often on the day after you, again, start something new or increase the dose, or a few days after that once it gets up to steady state in the blood. Akathisia is poorly understood in terms of why it happens, and the treatment of it is either benzodiazepines or things like beta blockers, although the literature is mixed about to what extent those medications actually treat the akathisia or just make it more tolerable. So generally the treatment for akathisia is reducing the dose of the antipsychotic or switching the medication. Again, I want you to pause and write down which extrapyramidal symptom comes next in the progression. I learned it as about 4 weeks, although that's fairly generous. Write down the name of it, the description of it, and what you would do to treat it. So the next symptom is drug-induced Parkinsonism, which has classic features of Parkinson's disease, including shuffling gait, tremor, bradykinesia, sort of all the other things we would think about being associated with Parkinson's disease. It can occur within a few days of starting a new medication or increasing the dose. It can take weeks, generally does occur within the first couple months. And the treatment for drug-induced Parkinsonism is usually anticholinergic agents, because again, they restore balance in the substantia nigra, reducing the dose or switching to a different medication. The most useful treatments for Parkinson's disease, which are dopaminergic agents, are not useful in this setting because although they would probably correct the Parkinsonian symptoms, they also would probably worsen the psychosis that you're trying to treat with the antipsychotic, which is working by blocking dopamine. So finally, what extrapyramidal symptom occurs at the longest time course, 4 months or 4 years? How is it characterized, and how would you treat it? So that's tardive dyskinesia, right? So tardive dyskinesia is generally characterized by involuntary, unconscious movements, often in the face and neck, but they can be in the body. Those movements tend to be repetitive. They tend to be repressible if the patient focuses on repressing them, although I have seen cases severe enough where it was not. And they tend not to interfere with function because they're repressible. So if you're talking, then and you have tardive dyskinesia, then often the tardive dyskinesia remits while you're talking, or shifts to a different part of your body while you're talking, and then returns to your mouth or face when you're done talking in an unconscious way. Now, tardive dyskinesia can occur from generally weeks to months to years into the course of taking antipsychotic medications. There's also data that tardive dyskinesia predated the advent of antipsychotic medications, and so patients with schizophrenia are at some baseline risk of tardive dyskinesia. There are also other medications that can cause it. It's worth noting, too, that tardive dyskinesia can be a withdrawal symptom from a rapid discontinuation of antipsychotics or a rapid decrease in dose. So in order to treat tardive dyskinesia, we can use anticholinergic agents, we can use benzodiazepines, we can switch to a higher potency or higher dose of antipsychotics, although you can only do that for so long. And one of the core interventions is stopping the offending agent. Now, if you stop an antipsychotic because of tardive dyskinesia and stop it rapidly, there's about a 1 in 3 chance that the patient will have an acute worsening of their dyskinesia because they will have that withdrawal dyskinesia. If you taper it, that risk is reduced. Then, regardless of whether they had withdrawal dyskinesia or not, there's about a 1 in 3 chance that ultimately, having stopped the offending agent, their tardive dyskinesia will substantially improve. It's rare that it goes away completely. It's about a 1 in 3 chance that it will somewhat improve, and a 1 in 3 chance that it really won't improve much with the discontinuation of that agent. Finally, we want to turn our attention to the anticholinergic side effect profile, which hopefully you're already familiar with. I want you to stop and write down a list of anticholinergic side effects that you can think of now. Right, and so I learned this as, atropine overdose, blind as a bat, dry as a bone, red as a beet, etc. Those side effects include dry mouth, which can ultimately lead to cavities or sore throats, urinary retention, constipation, or even ileus in severe cases, photophobia, blurred vision, sedation. In acute angle glaucoma, you can have an increase in the intraocular pressure, which can actually be quite dangerous and lead to blindness. Anticholinergic side effects include ataxia and orthostatic hypotension, which are particularly important in our geriatric population. So now, shifting to looking at the medications rather than the side effect profiles, if we think about typical antipsychotics, what I want you to think about is that these medications generally involve a balance between dopaminergic and anticholinergic side effect profiles, and that you can predict the side effect profile of a typical antipsychotic by just knowing or looking up the average effective daily dose in milligrams of that medication. And that's because there is a linear, this is actually logarithmic, but there's a linear, logarithmic, inverse relationship between dopamine receptor affinity and average effective dose. So on the x-axis here we have the average effective daily dose, and on the y-axis we have the dopamine binding affinity. And what we see here is that the more tightly your typical antipsychotic binds to the dopamine receptor, the less of it that you need. So those are the ones on the lower left corner. The less tightly it binds to the dopamine receptor, the more of it that you need. Those are the ones in the upper right corner. And that this relationship is clearly sustained. The degree to which these data points adhere to the line really does support the argument that dopamine blockade is the mechanism of action for typical antipsychotics. I will also tell you that there is a direct relationship between the average effective dose and the amount of anticholinergic side effects that it causes. So as your daily dose goes up in milligrams, then the rate of anticholinergic side effects also goes up. So the lower the average daily dose, the higher the risk of dopaminergic side effects, and the lower the risk of anticholinergic side effects. While conversely, the higher the average daily dose, the lower the risk of dopaminergic side effects, and the higher the risk of anticholinergic side effects. Now let's pause and think this through. So for high potency agents, those with low average daily doses, it makes sense. They don't have a lot of anticholinergic side effects, but they do act by blocking dopamine, so we would expect them to have high amounts of dopaminergic side effects. That makes sense. But if we look at the low potency agents, which are the typical antipsychotics that bind poorly to the dopamine receptor and therefore have high daily dose requirements, we still understand that they ultimately work by blocking dopamine. And so we would expect them to have relatively high rates of dopaminergic side effects, regardless of the fact that they don't have a high affinity because you just take a lot of them. But we also have to remember that the rate of anticholinergic side effects goes up in those medications, and that anticholinergic agents are actually a treatment for dopaminergic side effects, particularly the extrapyramidal symptoms, not so much the tuberoinfundibular side effects. And so essentially our low-potency typical antipsychotics have extrapyramidal side effect treatment built in by having high anticholinergic side effect burden. Let's look at a few examples. So haloperidol is a high-potency agent with an average dose of 5 to 15 milligrams required each day for treating schizophrenia. I want you to stop and write down what side effect profile you would expect with haloperidol. And what we see is that there's a very high potential for extrapyramidal symptoms, although how high depends widely on what study you look at, and that there are quite low rates of anticholinergic side effects associated with Haldol. Begs the question, why do we think of Haldol as sedating? And my answer to that is that it's a little bit sedating in and of itself, but also we want to think about what's it traditionally given with in the emergency department. So it's given in what's called a B52, or colloquially called a B52, which involves 50 milligrams of IM Benadryl, 2 milligrams of IM Ativan, and 5 milligrams of IM Haldol. Why is it given in this way? Well, it's given in this way to minimize the risk of extrapyramidal symptoms. We talked about both benzodiazepines and antihistamines as being good management agents for acute dystonic reactions, and that's what we're worried about in this setting because Haldol is a high-potency agent. Now, of course we think of it as being sedating. If anyone were given 50 of IM Benadryl and 2 of IM Ativan, they would experience it as sedating. But it's not the Haldol that's the sedating part, it's those agents. The Haldol is the one that puts you at risk for the extrapyramidal symptoms that we are then trying to prophylax against with those agents. Moving on to a medium potency agent, perfenazine, also known as trilofan. So perfenazine has an average daily dose of 30 to 50 milligrams a day, and we would expect to see, as you might imagine, moderate rates of extrapyramidal symptoms and moderate rates of anticholinergic side effects. Sometimes you kind of win the lottery twice, or your patient does, and they have relatively low rates of both. Sometimes they kind of lose the lottery twice and have relatively high rates of both. And sometimes they split the difference in one way or the other. It's really hard to predict. Finally, looking at a low-potency agent, thorazine, or chlorpromazine, has an average daily dose of 400 milligrams a day or more. When we think about the side effect profile of thorazine, there really are essentially minimal risk of extrapyramidal symptoms, but it is very sedating and very anticholinergic. And so if you think about the stereotypical psychiatric ward from the 1960s, patients are shuffling, sort of cognitively impaired, very sedated, amotivated, etc. And that's probably due to three things. One is just the way that they're portrayed. Two is the relatively high rates of lobotomies, frontal lobotomies. But three is thorazine, which was developed in the 1950s and was the first of the antipsychotics, was widely used at that period of time, and caused lots of anticholinergic side effects. And so that image of kind of the thorazine shuffle, or some people used to call it thorazine zombies, is really an image of an anticholinergic side effect profile. Now, as we turn our attention from the typical to the atypical antipsychotics, we need to start thinking more about metabolic side effects. So, take a moment and write down what metabolic or antihistaminic side effects atypical antipsychotics are associated with. And those include weight gain with consequent osteoarthritis, lumbago, social isolation, all of the negative side effects we think of with weight gain. They include sedation, hypercholesterolemia with its associated risks of cardiovascular outcomes and strokes, hypertriglyceridemia, insulin resistance and diabetes, which is also an issue with typical antipsychotics. Of course, diabetes can cause vision problems, ultimately blindness, renal problems, ulcers, amputations, etc. It's also worth knowing that there are clear studies from the era before antipsychotics that showed that patients with schizophrenia have a baseline dysregulation of their glucose and are at increased risk of diabetes regardless of these medications. So this worsens that risk even further. And the metabolic side effects also include metabolic syndrome, as we mentioned. So atypical antipsychotics involve kind of a balance between metabolic and dopaminergic side effects, but they don't adhere to the line quite as nicely as the typical antipsychotics, so we'll just go through the individual agents that you'll most commonly see. The first of those is clozapine. So clozapine is a remarkable agent for a number of reasons. It's been repeatedly shown to outperform other antipsychotics in refractory cases of schizophrenia, as we discussed earlier. But it's generally only considered for refractory cases because the risk of agranulocytosis, which requires that the patient get intensive CBC monitoring, and that both patients and providers need to be on a national registry in order to be prescribing or receiving this medication. It has minimal, if any, dopaminergic side effects because it has very low dopamine affinity and high anticholinergic side effect burden. It actually can be used to reverse tardive dyskinesia, but unfortunately it causes significant weight gain, causes significant sedation, potential myocarditis, and potentially life-threatening constipation or functional ileus because it's so potently anticholinergic. It also idiosyncratically causes drooling in some patients. And so clozapine is a very effective medication with a very significant side effect profile. Turning to olanzapine, so multiple studies show that it's probably slightly more efficacious than other antipsychotics except for clozapine. Olanzapine is characterized by a moderate dopamine blockade and a moderate risk of dopaminergic side effects, but a significant risk of weight gain and sedation that are the worst of any antipsychotic other than clozapine. Also significant risk of all the other metabolic side effects, hypercholesterolemia, hypertriglyceridemia, diabetes, etc. Looking now at risperidone. So risperidone is the most potent, the most dopaminergic of the atypicals, and so it has the highest rates of hyperprolactinemia, up to 40% in some studies, and the highest rates of extrapyramidal symptoms. It does still cause significant weight gain and sedation, but it's not as offensive as olanzapine or clozapine. Looking at quetiapine or Seroquel. So quetiapine has very low affinity for dopamine receptors, so it essentially has no dopamine blockade. So for example, in patients with Lewy body dementia who are hallucinating, quetiapine is one of our go-to agents because it's got the lowest risk of worsening the Parkinsonian symptoms that may be associated with that illness. Quetiapine does, however, have significant weight gain and sedation, again, not as much as olanzapine or clozapine, but still significant. Aripiprazole, or Abilify, is a partial agonist at the dopamine receptors. People were really hopeful that it would have dramatically improved side effect profile because of that. It doesn't really. It does generally cause less dopaminergic side effects. It can actually be used to reverse the hyperprolactinemia associated with other medications, but it has high rates of akathisia, as high as 25% or more in some studies. It causes less sedation and less weight gain, but it still does cause those problems. Ziprasidone or Geodon is weight neutral, minimally sedating, the moderate risk of dopaminergic side effects, but unfortunately the highest risk of QTc prolongation, and unfortunately you have to take it with a 500 calorie meal twice a day, which many of our patients struggle to be organized enough to take it. I don't have a slide on lurazidone, which is a relatively newer medication that's related to ziprasidone. Like ziprasidone, lurasidone is weight neutral, minimally sedating, with a moderate risk of dopaminergic side effects. It actually has no risk of QTC prolongation. It is evidence-based in both schizophrenia and bipolar disorder. You do, again, have to take it with a significant meal, sometimes just once a day, though. So I want to move from the individual atypical antipsychotics to discussing risks that apply to all of the antipsychotics, typical and atypical. The most dangerous of those is neuroleptic malignant syndrome. Now, neuroleptic malignant syndrome is a life-threatening condition. It's characterized by muscular rigidity, which can result in rhabdomyolysis and renal failure, autonomic instability, including hyperthermia, tachycardia, very labile blood pressure, delirium, catatonia. It tends to occur fairly quickly after starting a medication or a dose increase, and almost always within a month of those happening. And the treatment is immediately discontinue any antipsychotic medications or any dopamine blocking medications, which some antiemetics work in that way as well. And then supportive care. This is considered a medical emergency. People can certainly die of neuroleptic malignant syndrome. People often end up in the intensive care unit for neuroleptic malignant syndrome. And so the scope of treatment for NMS is beyond this lecture, but it's worth knowing that this is this is a shared risk associated with antipsychotic medications. It doesn't occur common, but it is common to all of the medications. All antipsychotics are also understood to decrease seizure threshold. It's hard to characterize how much, although clozapine is very likely the most offensive in that regard. All antipsychotics have been shown to increase the rate of all-cause mortality in dementia patients over the age of 65. This is likely due to a combination of cardiovascular effects, fall risk, and other contributions, and the risk roughly doubles from about a 2% to a 4% annual mortality rate. In my experience, by the time we're using antipsychotics to manage the agitation associated with dementia, generally we're prioritizing quality of life over quantity of life, and generally we're consenting family members rather than the patient. I've never had a family say don't use those medications because of this increased risk, but it is absolutely important to consent the patient, if they're capable, or the relevant family members, to this increased risk. Almost all antipsychotics can prolong QTC. So on average, that prolongation is very minor, 5 to 15 milliseconds, but in some patients it's larger, and some patients have congenital prolonged QT syndrome, which puts them at higher risk even of a minor prolongation. And we know that above 500 milliseconds, the risk of Torsades de Pointes goes up significantly, which is a potentially fatal arrhythmia. The two antipsychotics that are safest from a QTC perspective and really don't affect QTC would be aripiprazole or Abilify and lurasidone or Latuda. So trying to put all this together, how are we going to pick an antipsychotic for our patient? And I think the answer is ideally they'll pick an antipsychotic for themselves. They're the ones who will be exposed to the risk of the side effects that we've been discussing. And so it's really our job to help them understand those side effects, and then they need to prioritize which risks they're willing to run compared to which risks they're less willing to run. Unfortunately, it's often the case that we're picking antipsychotics for patients who are too ill to be involved. They're too psychotic, too agitated, too manic, etc. And so often route of delivery is an important consideration. So what I have here is a chart of the various routes of delivery and which antipsychotics are available via those routes. So we can see that in terms of IV, there is a long history of using IM Haldol in IVs, and so we know that it's relatively safe, and we do it quite frequently. So that's really the go-to antipsychotic for IV use. Technically, there are case reports of using olanzapine IM in an IV in a very similar way, and it seems to be fine, but Haldol's by far the most well-known of the antipsychotics to be used IV. In terms of IM, so of the typicals, Haldol, fluphenazine, perfenazine, chlorpromazine, there's actually quite a few of the typicals are available in intramuscular form. Of the atypicals, we have olanzapine and ziprasidone that are available in short-acting intramuscular injections. There are orally dissolvable formulations of some of these medications for patients who you're worried are going to cheek the medication and try to spit it out later, but who you're not worried would try to bite the nurse's fingers or something. So none of the typicals that I know of are available in a dissolvable form, but risperidone and olanzapine are both available in that of the atypicals. All the antipsychotics are available orally. And then often we also want to think about long-acting injectable formulations for patients who struggle to keep taking their medication. And so you can see here there's a pretty good list of both typical and atypical agents that are available in long-acting injectable forms. So as we help our patient pick an antipsychotic, again, I encourage you to collaborate with them as much as possible. To remember that to a degree that's not really supported by the evidence, atypicals have replaced typicals in most cases as first-line agents, that clozapine is dramatically underutilized. I often see patients on 2 or 3 antipsychotics, which, as we'll discuss, is not evidence-based, but in whom no one has tried clozapine or offered clozapine to. And I encourage you to think about long-acting depot injections for patients with poor medication adherence histories. Now, what do you do if your patient isn't getting better even though the dose of their antipsychotic is maxed out? Well, I would encourage you to think about switching to another agent like olanzapine or clozapine, because the use of multiple antipsychotics is not supported by the evidence base, right? There is good evidence that you'll give them more side effects, and because of that, Obamacare includes monitoring for the use of multiple antipsychotics because it's just not an evidence-based thing to do. Now, if you're working at a state psychiatric hospital with chronically, severely mentally ill patients, often you may be off the evidence base because you've already tried everything else. But in general, the use of multiple antipsychotics is not supported by the evidence, nor is there evidence for exceeding the FDA recommended doses. The FDA recommended doses are recommended maximum doses because that's where you hit the flat part of the dose response curve. Increasing the dose further just increases your risk of side effects. So let's turn our attention to a case. So we've got a 33-year-old man with a history of schizophrenia brought into the hospital by police after jumping off of a 20-foot freeway overpass, shouting that he was being chased by demons. Now, after being medically cleared, remarkably, he's brought to the psychiatric emergency services in 5-point restraints, shouting that he'll kill one of the nursing aides for cursing his family and yelling at demons that no one else can see. So, what diagnoses would you consider, and what medications would you consider, and why? Let's stop and write those down. So I would think about substance intoxication, of course, and then about schizophrenia, or schizophreniform, or an acute psychotic disorder, depending on the time course of this. And in terms of medications, probably the first thing I'm going to think about is the idea that he's threatening to kill a nursing aide. He's probably not someone who I want our nurses trying to give oral medications to, so I'm thinking about how can I get medications into this patient through some other route. And I'm thinking about olanzapine, because it's available IM, it's highly sedating, and it's an effective antipsychotic. I'm thinking about haloperidol, again, because it's available IM. I probably would think about giving it with Ativan or Benadryl. I generally don't do both, in order to manage that risk of EPS. And because helping him be a little sedated probably would be useful in this setting. I might think about risperidone, although it isn't injectable, and I don't know that I would trust this patient with an oral disintegrating form. So I probably would go with olanzapine in this patient. Now, we have a 36-year-old woman with a history of schizophrenia who comes into your clinic requesting a second opinion on her medication regimen. She's been stable on risperidone for years, but she's gained 30 pounds, and her primary care doc has told her she's at risk for diabetes. She's also getting married in a few months, and she wants to start a family, but she hasn't had her period in 2 years. So I want you to stop and write down what you think is going on here, why she's not having a period, and then what you would recommend doing in order to help this lady. So I think she's probably amenorrheic because of hyperprolactinemia, secondary to risperidone, which again is a pretty high potency atypical antipsychotic. So aripiprazole, because it's a partial agonist, can actually reverse that hyperprolactinemia, as we mentioned earlier. So that might be very helpful in restoring her fertility. It also has lower rates of metabolic side effects than risperidone, and so it might help reduce the rate of increase in her weight and her risk of diabetes. We could think about ziprasidone. Ziprasidone is not going to reverse the amenorrhea in as evidence-based a way, but it might. We could try it. It's also weight neutral and relatively metabolically inoffensive, and so it would again reduce her risk of further weight gain and her risk of developing diabetes. We could think about switching to a medium potency typical. It wouldn't be the top of my list, but again, sometimes with those medium potency typicals, your patient kind of wins the lottery twice and they have relatively minimal side effects. The other thing I would think about is adding metformin. We haven't talked about that yet, but there is actually an evidence base that metformin reduces the weight gain associated with antipsychotics and significantly reverses infertility. One study showed that it restored fertility to more than 70% of the women who were taking it. And so the addition of metformin would be a very reasonable option for this lady as well. Finally, we'll wrap up with this case of a 76-year-old woman with a history of severe dementia who's admitted for failure to thrive. You're asked to consult by the medical team who's managing her electrolyte abnormalities and acute kidney injury secondary to dehydration. Her baseline is somewhat unclear, but since admission she's been intermittently agitated, she's pulling on her lines. The medicine team has put her in soft restraints, but would like your help in helping to pick a medicine. So stop and write down the answer to these questions. What diagnoses would you consider? What medications? What further workup would you need before you make a firm recommendation? And when you get a hold of the family, what would you tell them? So I would think about delirium and dementia, certainly. And I would think about haloperidol, because again, she's not going to very likely be cooperative with taking medications, so I would think haloperidol is available IV and might be useful. I'd think about quetiapine with its low dopamine blockade. I would have lower concern for extrapyramidal symptoms in this patient, although it is only available in oral form. But really, if we can get her to take it, pretty much any antipsychotic would be a reasonable choice in this situation. Before I made those recommendations, though, given her electrolyte abnormalities, I'd want to make sure we have an EKG, because let's remember that antipsychotics tend to prolong QTC with a couple exceptions. And assuming that the antipsychotic was helpful, I would be inclined to tell the family that there is this increased risk of all-cause mortality associated with antipsychotics in the demented elderly if we were thinking about using this in the long term. So that's kind of the end of the meat of this lecture on various medications in psychiatry. I hope that you found it helpful. I encourage you to review it as you need. There are a whole bunch of other slides, as you'll see, on various other classes of medications that we'll walk through quickly. Looking at the sedative hypnotics, specifically benzodiazepines. So benzodiazepines are GABA agonists, which act in a similar way, but not exactly the same as barbiturates, act in a similar way to alcohol. They're potent anxiolytics. They work very well at reducing anxiety, but they're generally reserved for short-term use, and they are highly addictive, and they do create a risk of rebound anxiety. Benzodiazepines are used to prevent or treat alcohol withdrawal. They're used to prevent or treat anxiety. They're used in anesthesia, and they are appropriately used in catatonia, often at very high doses. Benzodiazepines carry a similar tolerance and withdrawal risk to alcohol, including the risk of seizures, of delirium tremens, of vital sign instability, and death, so they should not be rapidly discontinued. Benzodiazepines revolutionized the treatment of alcohol withdrawal and anxiety to some extent, as compared to barbiturates, which they largely replaced, because they do not depress respiratory drive if taken by themselves. So they're very significantly safer in single drug overdose. However, in combination with any other sedatives, alcohol, narcotics, barbiturates, etc., they contribute significantly to respiratory depression and can still be lethal in that setting. Looking now at our Z drugs, which are sort of non-benzodiazepine sedative hypnotics used to help with sleep. So they're selective GABA agonists, which were developed to replace benzodiazepines as sleep aid and don't have as much addictive potential as benzodiazepines. Some studies suggest that they don't separate from placebo as sleep aids for long-term use beyond 30 days, but otherwise they generally do what they were designed to do. They can be very helpful in sleep, and there are studies that suggest they may work beyond 30 days, so it's a little unclear. It's worth noting that the side effects include these sort of bizarre dysregulated REM sleep behaviors, massive sleep eating, sleep driving, which is obviously very dangerous. There have been case reports of sleep sex, so pretty much any behavior that you can imagine, these medications can cause people to engage in while asleep. Trazodone is not technically a sedative hypnotic, it's an antidepressant, but it's so sedating that it's primarily used as a sleep aid. It's worth noting that there is a 1 in 5,000 to 1 in 10,000 chance of a priapism in men, and any man who you're prescribing trazodone to should be consented for that risk. Priapisms are generally preceded by abnormal erections, so erections in unusual circumstances at unusual times, etc. And if those are happening in a man who's taking trazodone, that's an indication to immediately stop the medication. Looking now at medications that we use to help people maintain their sobriety. So the first one we'll talk about is disulfiram, or antabuse. Antabuse inhibits the activity of acetaldehyde dehydrogenase. So acetaldehyde is a byproduct of the metabolism of alcohol. And if you block acetaldehyde dehydrogenase, then acetaldehyde levels build up. It's a toxic substance. And so excess acetaldehyde produces this sort of violent acute illness characterized by vomiting, flushing, sweating, fevers, chills. It's pretty miserable from what I've seen and heard. And so antabuse is a very effective medication at preventing people from drinking if they take the antabuse. It's worth knowing that it may react with other sources of alcohol in sensitive people, and those can include mouthwash, hand sanitizer, cough syrup, etc., so you need to warn your patient about that risk. And it's also worth knowing that it's potentially hepatotoxic, less hepatotoxic than ongoing alcohol abuse, but it is contraindicated in people with hepatic failure. Looking at naltrexone. So naltrexone is an opioid antagonist that inhibits major reward networks in the brain. So it's useful in maintaining sobriety for multiple different classes of substances. In opioid use disorders, it just blocks the opioids from acting, and so it makes it impossible for patients to experience a high from that. It's very effective medication at stopping opioid abuse as long as people take it. In alcohol abuse, it decreases the rate of and the severity of relapse by reducing cravings and reducing those reward circuits if the patient does relapse. So evidence also supports its use in gambling addiction, and there's this combination naltrexone and bupropion that's FDA approved as a weight loss drug, so that's just worth knowing. Naltrexone is also potentially hepatotoxic, less so than ongoing alcohol abuse, and also less so than anabuse is. Acamprosate. So acamprosate reduces cravings in alcohol abuse, although the mechanism's not terribly well understood. The primary side effects are gastrointestinal, diarrhea, and nausea. It can be used in combination with naltrexone. It's not hepatotoxic, so it's kind of our go-to medication in patients with severe hepatic disease. It does need to be taken 3 times a day, which is quite inconvenient, and so that often puts people off of it. So methadone is a long-acting opioid that we use to treat opioid dependence. It occupies the mu opioid receptors and prevents both opioid withdrawal symptoms and reduces the possibility of getting high with other opiates if it's dosed high enough. It has to be dispensed through a federally approved program, and it does carry the same risks as any other full opioid agonists, including withdrawal, respiratory depression at too high a dose or if mixed with other substances, etc. Suboxone is a long-acting opioid partial agonist, buprenorphine, combined with an opioid antagonist, naloxone. Now, if you take it orally, which is how you're supposed to take it, technically sublingually, the naloxone has no bioavailability, so it doesn't do anything. And the Suboxone, or the buprenorphine in the Suboxone, provides activity, partial agonist activity at the mu opioid receptors, and therefore prevents withdrawal symptoms. It's also very high affinity, so it blocks other opioids from attaching to those receptors, so it prevents people from being able to get high on other opioids. It also prevents people from being at significant risk of overdose with other opioids. Now, the naloxone is there to prevent inappropriate use by injection. So if someone were to dissolve or grind up the Suboxone and inject it, the naloxone becomes significantly bioavailable and will induce a rapid withdrawal syndrome. So it's safer in overdose than methadone, like I said. It's also easier to dispense than methadone. It's a complicated medication, so I encourage you to think about using it when appropriate, but also to seek supervision. Looking at nicotine and tobacco dependence, so Chantix or varenicline is a nicotinic agonist that we use to help with smoking cessation. It carries a black box warning for serious neuropsychiatric side effects, including depression, agitation, suicidality, so close monitoring is warranted. And it's worth knowing that probably the most common side effect I hear people complain about, GI upset, but also insomnia and very strange and intense dreams. We also discussed, before we move on to ADHD medications, the fact that bupropion or Wellbutrin is also evidence-based in supporting people's tobacco cessation. Now looking at ADHD medications, so the backbone of treating ADHD is stimulants. They're appropriately used to treat ADHD, and really only ADHD, with maybe a few minor exceptions in geriatric depression or severe dementia cases. But overall, the evidence doesn't support their use as an adjunct medication in treating depression. There's really no evidence between methylphenidate and dextroamphetamine salts that's significant enough to drive your decision making, and you should remember at this point, generally we start with methylphenidate, but that's not at all a hard and fast rule. Essentially, in trying stimulants, once you've made a clear ADHD diagnosis, you try one class, and if it doesn't work, you switch to the other.
Stimulants have lots of side effects, including appetite loss, weight loss, insomnia, the potential for growth retardation in children, although how much is debated, certainly increased anxiety, hypertension, tachycardia, so lots of things we would want to be monitoring. And there's lots of different formulations in terms of how long the medication acts for, so there's generally a 4, 8, and 12-hour formulation of both the methylphenidate and the dextroamphetamine salts, and so you really just kind of tinker until you find the most effective regimen that also minimizes side effects. Non-stimulant ADHD medications include atomoxetine, which is a norepinephrine reuptake inhibitor that was initially developed as an antidepressant, but is now used as a second-line non-stimulant agent to treat ADHD in situations where the stimulants are intolerable, don't work, or where the patient is too high risk to put on a controlled substance. In general, atomoxetine has lower efficacy, but fewer and less severe side effects. The side effects are the same classes, so insomnia and appetite suppression, etc., but they tend to be less common and less severe. Alpha agonists, so guanfacine and clonidine, are alpha-2 centrally acting alpha-2 receptors that can be calming in ADHD patients, can be calming in anxious patients, can be used as adjunctive agents in managing alcohol withdrawal, can be helpful in other behaviorally dysregulated situations. They can be used in opioid withdrawal to mitigate sort of anxiety and sympathetic hyperarousal. And then prazosin is a centrally acting alpha-1 antagonist that's been shown to reduce trauma-specific nightmares in post-traumatic stress disorder and is sort of being investigated for daytime hyperarousal symptoms. So all of these medications carry the risk of hypotension. That's kind of the major side effect. Looking at medications that we use to treat dementia, so we would start with the acetylcholinesterase inhibitors, which include donepezil, rivastigmine, and galantamine. They all act in the same way to increase acetylcholine in the brain synapses, which somewhat counteracts the neuronal losses of acetylcholinergic neurons associated with Alzheimer's disease. They slow the loss of memory and the loss of function, but they do not delay the ultimate course or endpoint of the illness, so they don't change sort of the estimated longevity of the patient. They're generally well tolerated, but GI side effects are the predominant issue, and they can cause loss of appetite, which can worsen failure to thrive in patients with significant dementia. In moderate dementia, we often add memantine or Namenda, which is an NMDA receptor antagonist, which is also believed to slow the progression, but again, not the ultimate endpoint of dementia, by mitigating neuronal excitotoxicity. It really only outperforms placebo in moderate dementia or worse, and it is also generally well tolerated. References that you can look at for further information. My recommendations for places to look are in red, although these are all good sources of further information. And I hope this has been useful for you.